And we are live. Okay, so today, guys, we're going over the trauma assessment according to M.A.R.C.H, the acronym M.A.R.C.H, M-A-R-C-H. And this came out of the military. It was adopted into TCCC not terribly long ago. And it's gained so much traction in the medical community that actually a lot of people who learn it like to, including myself, like to use it for trauma calls in general, even things that have nothing to do with a tactical scenario. Trauma is trauma, right? And what's nice about M.A.R.C.H, as we're going to see in a second, is that it's very broad and all-encompassing. You can apply it to pretty much any situation, any kind of patient, and so I'm excited to go over M.A.R.C.H now. All right, so as is the case with any type of patient assessment, obviously the first thing that we always check is whether or not our patient is responsive. And you remember that when we went over the medical assessment, this actually determines what kind of algorithm we're going to go down. If we're going to go down an ABC algorithm, if they are responsive, or a CAB algorithm, if they are unresponsive. This is the American Heart method, right? Airway, breathing, circulation if they are responsive, circulation, airway, breathing if they are unresponsive, because you're thinking of a potential code. I got great news for you, and that is that we are going to follow M.A.R.C.H in this order, regardless of whether or not the patient is responsive or unresponsive. We're still going to follow M.A.R.C.H in this order because this is the order in which things will kill the patient. All right, so let's start off with M. We're going to use red because M is for massive hemorrhage. Massive hemorrhage. Okay, note please, the word massive. We're not just talking about cuts and dings and bruises. We're talking specifically about arterial bleeds, okay? Arterial bleeds. As in, tourniquet or combat gauze. Okay, we're talking about a quick screening of our patient when we first approach them, looking for giant puddles of blood, giant spurting, obvious arterial bleeds. And then we need to correct these things even before we get to airway, because if you think about it, you can survive with an unstable airway far longer, comparatively speaking, than you can an arterial bleed. Okay, so this is really our first focus. When we get to a trauma patient, this is the first thing that we want to check. Okay. So tourniquet or combat gauze. When we place our tourniquet, we want to place it as high up on the extremity as possible. Okay, and the reason for that is because, I don't know if you knew this or not, but arteries actually have the ability to retract. That's right, not just constrict and contract, they have the ability to retract, as in pull themselves up from their initial site upon being lacerated and severed, okay? So what can happen is, you put a tourniquet on, let's say right here. This artery that's right here has the ability to potentially retract past the point where you place that tourniquet, and now it's essentially slipped out from underneath the tourniquet. It's gonna continue to bleed, and in fact, not only is it gonna continue to bleed, but if you think about it, you have, depending on what the situation is, you could have potentially even created a little bit of an isolated compartment syndrome, because you just created a boundary for it that is now going to bleed into and further complicate the tissue that it's bleeding into and compressing. Okay, not good, right? So we want that tourniquet to be as high up as possible. Another reason to get into the habit of doing it this way is that when we're screening patients in the dark at 2 in the morning and you find that massive bleeding in the beginning of the assessment, by the fact that it's the beginning of the assessment, we may not really know a lot about what this patient's magnitude of injuries are. We may not have even had time to strip them all the way down and search them for everything possible. And so really it's quite literally a shot in the dark, trying to figure out what exactly their injuries are. And so by going as high up as possible, we eliminate the chance that if there is something we missed, we didn't miss treating it, right? If there's another lack up further the arm that we didn't know about, in this case, by going clear to the top, we eliminate the potential of that failure. Okay, we cut our chances of missing something down even without knowing about it. So that's why TCCC, the M.A.R.C.H algorithm. They have adopted the high placement of the tourniquet for years, and they teach it adamantly. Obviously, if that tourniquet is insufficient in controlling the bleeding, the next move is to place the tourniquet directly below it. And we're just stacking them right next to each other, right? Because again, we don't want to create any space where we could have compartment syndrome. Okay? All right, now that's for extremities, tourniquet extremity, right? We can't go placing tourniquets around people's necks, right? So if we have a bleed that's in what we would call a junctional site, that would be like a place, let's say the iliaco-pelvico type of region, basically the groin, right? Right where the iliac crest is, basically. Okay, so the leg has now become the pelvic region, or the shoulder region, where it's no longer amenable by placing something circumferential around the arm. This is the spot where we now begin to need to pack the wound, because we can't actually get a tourniquet wrapped around it. We have to punch something into it, okay? When we pack combat gauze, we need to pack it. And I mean, like, it's gonna suck for the patient. You're literally taking every last bit of that combat gauze and you are packing it in that wound as much as you can stuff in there. And when you push it in, I want you to push, I want you to displace the gauze as much as you possibly can into the tissue. This is gonna cause them to scream in pain. And it's one of those things where, like the tourniquet, the screaming in pain, assuming they're responsive, means it's working. It means you're doing it right. If they're not screaming in pain, you're probably not being aggressive enough. That sounds really, really horrible to say, I know. But again, we're talking about arterial bleeds. These need to be controlled properly, because guess what? You can still bleed out internally. We all know this, okay? And so just because it's not spurting arterial blood externally doesn't mean that A, it isn't an arterial bleed, and it certainly doesn't mean that it's not going to kill you. We need to treat the internal bleeds in the junctional sites just as seriously as we treat something that is obvious hose bleed that we're going to treat with a tourniquet, okay? All right. We'll go more over on packing wounds in another video, but for now I just want to hit the highlights so that we're just learning the algorithm, okay? So, M, massive hemorrhage. Moving on to A for airway. Now, what I like about this too is that A is airway, and R in the algorithm, M.A.R.C.H, R is respirations. What I like about this is that airway comes before respirations, just as airway comes before breathing in the regular ABCs that we all learn. And as we can all think back to our first EMT class where we learned ABCs, we learned that it really doesn't make a heck of a difference what your breathing is if you don't have an airway to begin with, right? So our first assessment, in our panicked, oh my gosh, I have a super traumatic patient at 2 in the morning and I'm half asleep state, is that the first thing that our monkey brains need to do is look for massive bleeds and correct them. And then once we've corrected them, the second thing that we need to look for is, do they have an airway? And is their airway patent? And the way that I do my airway assessment, I try to make it really simple on myself. This is just my approach. Take the one that you will. But I like to actually just start at the top and work my way down. I'll start generally, again, just with the mouth, work my way down to the trachea, and then work my way down to the lungs. And it basically goes like this. As I walk up to the patient, the first thing that I'm doing is I'm obviously taking that visual assessment in of, do they have any obvious secretions? Do I hear them breathing? Do I hear them gurgling? Do I even hear them speaking? And even if I don't hear them speaking, or even if I do, I'll typically first ask them, are you having trouble breathing? It's a great first question. Now, here's the thing. We all know that there's a huge difference in interpretation to that question. We've heard the, oh, God, I can't breathe, just as much as we've heard the, yeah, I'm having a really hard time breathing. I just feel like I can't catch my breath. It's so hard to breathe. And we're like, clearly you're not having trouble breathing. But it's really not so much how they answer the question or what they answer the question with. It's really more how they answer the question. We're looking at, we're using this as an opportunity, again, to get them talking and to listen to, do I hear gurgling in their airway? Do they sound like they're struggling to get a breath out? Are they guarding part of their chest as they speak, you know? And so again, we're just using this as a means of trying to figure out what the patency of their airway is. And that's kind of how I start clearing basically from the mouth down. As I'm looking at the head visually, I'm now working my way down to the trachea visually. I might even have them kind of lift their head, asking them, of course, first, do they have any pain in their neck? Are they able to move their head? And assessing their trachea for any deviation, any trauma, any compression, anything that would concern us with an impact of their airway there. And then as we move down to the chest, this is a great time to, if you have someone available, to start cutting off their upper clothing and start visualizing the chest, maybe even check lung sounds at this point if you see something concerning regards to your mechanism, or if, the answer to that question was, no, I can't breathe, and they're struggling, then okay, maybe you really do want to stop and immediately check lung sounds and consider your decompression right off the bat. That leads us to our treatment. So if we have an unstable airway, it is number 2 priority on the list, right? With, again, massive bleeds being first, airway being second. Just like in the ABCs, and I want to re-emphasize that when we're going through our algorithm, when we get to a letter that we have deemed this is not good, it needs correction, you need to stop and correct that before moving on to the next part of the algorithm, right? So we come up and we identify they have a massive bleed. We're not going to jump to correcting the airway until we've corrected the bleed. And now in this case, we've gotten to the airway and we've deemed, oh crap, their airway sucks. We're not going to move on to C and H of the M.A.R.C.H algorithm until we have locked down that airway. Okay? Super important. So, what are our treatments for the airway? Well, obviously on the BLS side, and BLS always comes before ALS, we need to consider whether or not they're on the upper side. We need to consider whether or not they need to be ventilated. Are they breathing adequately on their own? If the airway is not patent in their upper airways, we need to consider suction. And on the lower side of the airway, the lungs, we need to consider if they are having trouble breathing, and the mechanism has indicated that, yeah, there's probably some penetrating injury in the chest, and we go search and find, yes, this is in fact true, then of course, chest seals for any open penetrating chest injuries, right? So gunshot wounds, stab wounds where the knives come back out, something like that, right? So we patch holes in the chest cavity, and then of course in the upper airways we're considering suction if something needs to be removed. We're considering ventilation if we feel like they're not breathing adequately enough on their own, whether it's too fast and insufficient or it's not enough. And then comes the delivery of oxygen itself, okay? So I want to stress something here too, that with the airway comes our realization that high flow oxygen is really going to be at the top of our considerations even before we fully know what's going on, under a few circumstances. Not all circumstances, but a few. One is going to be shock. If you see anything in this patient and your general impression that leads you to believe shock is possible, or they look shocky, right? Their skin is diaphoretic and pale, or you just corrected a massive arterial bleed, I want you to just feel free, especially on the BLS side, if you don't have a paramedic with you. I want you to be free to just go ahead and place high flow oxygen, okay? Being that you have removed any, obstruction of their airway that you need to, of course. Go ahead and place them on high flow oxygen, okay? And the reason for this is twofold. One, there's a good chance if they're shocky, you're not going to get a blood pressure because it's not going to be readable. And what we have seen, kind of looking back over some of our own calls, as well as calls run by other departments, is that when people tend to have a delay in obtaining a vital sign that would indicate a certain kind of treatment, they also tend to delay giving that treatment. So in other words, if they can't find the definitive SpO2 is below 94%, there's oftentimes a delay in their reports on giving the oxygen. If there's a delay in finding blood pressures below 90 systolic, there's often a delay in treating for shock, okay? It's almost like our brains have to identify the number before we can give the treatment. But I want you to be free to treat also based on obvious context. If a patient doesn't have a palpable blood pressure, they're probably in shock, are they not? Right? And so feel free to just go ahead and place that high flow oxygen on. If you want to later, titrate them down upon them recovering and see where they're at, that's awesome. But in the meantime, might as well, right? If it's not going to hurt them, you may as well be more aggressive, right? The second thing, so shock was the first thing. The second thing is going to be head injuries, all right? And the reason for that is, again, twofold. The first thing is that They have found that high flow oxygen in the presence of a head injury increases survivability by a significant percentage. Cool. But the next big thing is actually even more cool. Giving oxygen actually allows vasoconstriction, which in the case of a head injury that has increased intracerebral pressure, that's pressure increasing inside the head, okay? And that's not good because the skull is a closed vault. It doesn't have any, expandability. It will actually cause pressure in the head to go down. And the reason is that, again, it's constricting the vessels. When vessels constrict, they take up less space. When they take up less space, all of that pressure that's expanding in the head is able to, not be as expanded. So it buys you a little bit of intracerebral space, okay? So again, this is something that you can correct early on the BLS level, and BLS before ALS, right? And so there's just really no good reason not to do it, especially in the early stages when you've arrived, you've found this critically ill trauma patient, you've just corrected a massive bleed perhaps, or maybe they just have a massive head injury. Just go ahead and throw high flow oxygen on them, okay? There's actually a third reason that I'm going to surprise you with now. The third reason is that especially if you are rendezvousing with ALS and this is a patient where we may end up needing to take their airway, it's really important that we set up a good intubation if we need to do one by doing what's called pre-oxygenation and denitrification. Oh boy, big words. Really all it means is that the more oxygen we can shove into their lungs, the more of their reserve oxygen supply we can build up, the better chance they have of having a successful intubation where they don't die in the middle of it. Okay? So, really that simple. It's really not complicated. So, those three reasons. Oxygen, oxygen, oxygen. Okay, next airway pearl. So, this is good. If we're going to ventilate, so we just talked about oxygen delivery and using high flow aggressively. If we've deemed that we actually need to go all the way to a BVM, anytime we place a BVM, I want to train something into us as part of our default programming system. And our default program for a BVM is that anytime we are bagging someone with a BVM, they need to have an adjunct, either an OPA or an NPA, every time. They need to have that bag hooked up to high flow oxygen. That sounds like a no-brainer, but it doesn't always happen. Sometimes people are just bagging regular atmospheric oxygen. 3, it needs to have a PEEP valve, and that PEEP valve needs to be set to 5 centimeters of water. That's the pressure on the side. Again, don't worry about the centimeters water. It's just a measurement of pressure. Just dial it to the 5. There's a big 5 on the side. Turn that sucker till it's at 5. You're good, okay? But it needs to have a PEEP valve set to 5 on it, especially in trauma. The third, or what are we on? Oh my gosh. We hit, okay, I'll just say the next. The next thing that we need to have on there is end title, okay? This is on the paramedic side. You don't really need to worry about colorimetric end title on a regular BVM not hooked up to a tube if on the BLS side, but this is more for the paramedics. You need to have inline end title going. And if you're an EMT working with a paramedic, also note, just go ahead and put that on there for them. They will love you for it, okay? Get some end title, the inline end title hooked up to the BVM. So we have BVM hooked up to high flow oxygen with the reservoir all the way full. Next should be a PEEP valve set to 5 centimeters water. Coming down from the BVM should be an inline end title, and then you should have the mask, and then there should be an adjunct, an OPA or NPA in the patient, depending on indications. Okay? All right. So that's the tower of power that we're going to call it, and we need to make that our habit of putting on every single patient who's receiving bag valve ventilations. Whew! We've now made it to C. Okay, C for circulation. Just like in the ABC. Circulation as differentiated from massive hemorrhage. Why? Because bleeding is one thing, but now we want to actually know their hemodynamic status. And hemodynamic status really just pertains to how well is the patient perfusing. So this is looking at their blood pressure primarily, their heart rate, their SpO2. Basically, we're trying to analyze, big picture, are they in shock, are they not in shock, or are they headed to being in shock? And then what do we need to do to correct that so that we prevent them from going into a decompensated shock state? Obviously, our primary modality of treating shock in the trauma state is going to be with fluids. All right, and the last one here, H, actually stands for several things, and three primarily. And you know that I really don't like acronyms that have multiple words for the same letter, but can't get away from it here. I didn't create this one. It just is what it is. But they're all really important. The first one is hypothermia, which reminds us of the diamond of death, right? Hypothermia is a big one because if your temperature is too low, basically, you can't form clots. Also, some of our medications can lose efficacy. So you got to correct their temperature, or at least keep them warm enough. Otherwise, they're going to continue to spiral down the drain. The next thing that H reminds us to think of is head injury. We've already talked about it a little bit earlier with the airway stuff, but really this is also helping us to think about CSMs, inline spinal immobilization and stuff like that, right? So head injury, there's the second H, and then the third H is history. Most specifically, what kind of things do we want to know, especially in trauma? Well, we want to know what their medical history is. We want to know, are they on blood thinners? Because that's going to, matter. We want to know the history and mechanism and nature of the incident itself, so we better understand what the patient had happened to them. Okay, so dynamics of the wreck, if it's a crash, what speeds were they going, right? Things like that. Did they lose consciousness? Did they crash because something caused them to crash, or was this just a crash that was induced mechanically? But we also, again, want to look for specific medications in their history that are going to tell us, oh shoot, some of our meds may not have full efficacy either. And the big one with that would be if the patient is on beta blockers. So we can ask if they're on blood thinners, because that's going to worry us for quicker bleeding that we have to potentially work harder to correct. And the second thing, right off the bat, for home medications that would concern us are beta blockers, because then if we go to give them certain types of medications to try to increase their sympathetic nervous system, it might be a little harder if they have a beta blocker on board preventing that. Okay? Rock on. All right. M.A.R.C.H, massive hemorrhage, airway, respirations, circulation, and then the H's, hypothermia, head injury, and history. Okay. So really pretty simple. Just again to recap the big stuff here. Regardless of whether or not they're responsive or unresponsive, we're doing M.A.R.C.H in that exact order. And also, it goes without saying, it doesn't mean that when we say go in order, it doesn't mean that you can't be doing multiple things at the same time. Common sense applies here. We only teach that order specifically for the situation where either you are by yourself and you have to work by yourself, or just for the general purposes of a teaching point so that we understand the order of priorities. Obviously, we all work as a team. If we can sub-delegate out multiple things to happen simultaneously, that would be the gold standard, and that's what we're aiming for. But again, we understand the order of importance. So, M.A.R.C.H, I hope this helps. Apply it to all of your trauma calls if you want. Practice it, practice it, practice it. I hope that it helps. All right, peace out. Thanks for watching. For an outline and notes on today's talk, be sure to visit the TLS training website.